So as everybody is getting settled in, I wanted to also introduce this new session that we have for SABCS, a rapid fire session. This is a session with abstracts that will have short presentations. The studies are extremely critical in how we develop our larger future trials, and these are really very thought-generating trials, maybe not necessarily changing our standard of care, but really shaping how we perform our research in the future. So I want to thank all of the speakers for today's presentations. We will not have a Q&A after each of the talks, but you can all find the speakers after the session. So our first abstract is going to be a multicenter phase 1/2 trial of Anastrozole, Palbociclib, Trastuzumab, and Pertuzumab in hormone receptor positive, HER2-positive metastatic breast cancer, the ASPIRE trial, presented by Dr. Amy Tiersten.
Thank you on behalf of myself and my colleagues for the opportunity to present this trial. These are my disclosures. The study was funded by Pfizer. Standard of care frontline treatment for hormone receptor positive, HER2-positive metastatic breast cancer consists of cytotoxic chemotherapy and the HER2 targeting antibodies Trastuzumab and Pertuzumab. Crosstalk between HER2 and ER signaling pathways may contribute to endocrine resistance. Anti-HER2 agents in combination with anti-estrogen therapy may restore endocrine sensitivity. HER2 signaling promotes cell survival by way of PI3 kinase AKT activation, whereas ER CDK4/6 RB signaling promotes cell cycle progression. Therefore, combination of dual antibodies with anti-estrogen therapy and a CDK4/6 inhibitor would interrupt both pathways and provide a novel, all-biologic, chemotherapy-free approach to the treatment of hormone receptor positive, HER2-positive metastatic breast cancer. In terms of eligibility criteria, men or women with ER or PR at least 1% and HER2 positivity were eligible. This was a frontline study, so patients had no prior systemic therapy for metastatic disease. Patients with measurable or evaluable disease were included. In the phase 1 portion, we accrued 9 patients, the first 3 patients at a dose of palbociclib of 100 milligrams, and then 6 additional patients at the next dose level of 125 milligrams using a 3+3 design. The palbociclib was combined with standard dosing of anastrozole, trastuzumab, and pertuzumab, and the primary endpoint of the phase 1 was the MTD. A GnRH agonist was added for premenopausal women and men. In the phase 2 portion, we accrued an additional 24 patients at the MTD, so there are 30 in the cohort for analysis, and that was at the MTD of palbociclib of 125 milligrams, day 1 through 21, followed by 7 days off, again with standard dosing of the other agents. And the primary endpoint for the phase 2 portion was clinical benefit rate, and secondary endpoints of progression-free survival, objective response rate, and safety. In terms of patient characteristics, the median age was 57.6, 72% of the patients were white, 72% of the patients were postmenopausal, 43% had de novo metastatic breast cancer, and 63% had visceral metastases. There was 1 male on the study. Oops. In terms of response, the clinical benefit rate was 97%, objective response rate 73%. There were 4 CRs, 18 PRs, 7 patients had stable disease. No patients had progressive disease as their best response. The median time to overall response was 2.8 months. Median duration of response, 37.8 months, and median follow-up at this time is 30 months. The median progression-free survival was 21.2 months. Median overall survival has not yet been reached. Only one patient has died after 2+ years on protocol. In terms of toxicity, the regimen was well tolerated with the safety profile consistent with the known toxicities of the individual agents. The most common toxicities were neutropenia, diarrhea, and leukopenia. There was one patient who had to discontinue Trastuzumab and Pertuzumab 3 months into the trial due to cardiac toxicity, but she remains disease-free on study for more than 4 years on Anastrozole and Palbociclib. In conclusion, the Monarch Hair trial previously demonstrated increased efficacy of the combination of abemaciclib, fulvestrant, and Trastuzumab compared to chemotherapy plus Trastuzumab in patients with hormone receptor positive, HER2 positive, metastatic breast cancer with at least 2 prior therapies, and the median on that trial was actually 4. Our trial found that the combination of Anastrozole, Palbociclib, Trastuzumab, and Pertuzumab in the frontline setting was well tolerated and effective with a clinical benefit rate of 97%, including patients with visceral disease and premenopausal women. This combination can provide a chemotherapy-free frontline regimen. I would like to acknowledge our dear colleague, Dr. Crystal Cascetto, who worked hard on this protocol when she was a fellow. I would like to thank my colleagues, the research staff, the patients, and thank you for your attention.
Our second abstract is BBO 10203, a first-in-class, orally bioavailable, selective covalent small molecule that inhibits RAS-driven PI3Kalpha alpha activity without affecting glucose metabolism, by Dr. Pedro Beltran.
Thank you, Dr. Kakmani, and thank you to the organizing committee for the invitation to speak to you today. We're very excited to share our preclinical data on targeting RAS-driven PI3Kalpha alpha activation in human tumors. These are my disclosures. I'm an employee of Rich Biopharma. So in normal cells, we know that activation of PI3Kalpha alpha and AKT happens through the activation of receptor tyrosine kinases like IGF-1 receptor and insulin receptor that leads to signals that contribute to cell growth, survival, and sugar or glucose metabolism. In the malignant context, however, it has been described that RAS is able to complex to the plasma membrane, complex with PI3Kalpha alpha, leading to either priming or direct activation of PI3Kalpha alpha, leading to activation of AKT, contributing to that sustainability of the malignant phenotype. In order to interrogate this biology, or underappreciated biology, we have developed BBO 10203. This is a small molecule covalent inhibitor that binds to the RBD domain, the RAS binding domain of PI3Kalpha alpha, and prevents the physical interaction between RAS and PI3Kalpha alpha at the membrane. That leads to inhibition of AKT and inhibition of cell growth, survival, and potentially glucose metabolism in tumor cells. BBO 10203 is a first-in-class PI3Kalpha alpha RAS breaker that targets RAS-driven PI3Kalpha alpha signaling in human tumors. BBO 10203 is selective for the interaction of PI3Kalpha alpha and RAS. It does not inhibit beta, gamma, or delta isoforms. Importantly, it does not inhibit the kinase activity of PI3Kalpha alpha. It does not block it blocks the interaction with K, H, and N RAS isoforms. BBO 10203 results in dose-dependent target engagement with phospho-AKT inhibition in multiple cell types, but no hyperglycemia or hyperinsulinemia, and results in tumor growth inhibition. So we have leveraged the data that shows that HER2 amplified cell lines are highly sensitive to PI3Kalpha alpha inhibition, and we show here 4 HER2 amplified cell lines and 3 HER2 expressing cell lines, and you can see a dose-dependent, very potent inhibition of phospho-AKT in the single-digit nanomolar IC50. The U87MG cell line, P10 null cell line here is used as a negative control. 3 take-home messages from BBO 10203. First, this molecule is about 50 times more potent than alpelisib, a kinase, PI3Kalpha alpha kinase inhibitor, when inhibiting phospho-AKT. As I mentioned before, it does not inhibit the kinase activity of PI3Kalpha alpha, and that allows it to get selectivity in cells normal cells or tumor cells in which RAS is not driving that PI3 kinase alpha activity. So, for example, here in the A375 BRAF mutant cell line, you can see very different profile than what alpelisib shows. BBO-10203 also has excellent ADME properties. So this is pharmacodynamic data in 2 tumor models, the BT474 model and the KYC410 model. And you can see that increased dose of BBO-10203 results in increased exposure and results in increased inhibition of phosphoic AT, which is comparable to what alpelisib gets at the 20 mpk dose. Importantly, 3 times the exposure of BBO-10203 that is required to inhibit 80% of phosphoic AT and lead to tumor regressions does not lead to hyperglycemia. So you can see here in the gold standard test for hyperglycemia, male mice are fasted overnight, then they're dosed with compound, and an hour later challenged with bolus glucose. And you can see how BBO-10203 does not differentiate from vehicle, what alpelisib, both at the 20 mpk dose and the 50 mpk dose, leads to the known hyperglycemia, and the same is shown with C-peptide for hyperinsulinemia. Finally, BBO-10203 drives a strong monotherapy activity in HER2-expressing models, KYC tumor model here, and the MDA and B453 models. You can see nice dose-dependent tumor growth inhibition between 3 and 30 mpk, with the 30 mpk dose resulting in tumor regression and tumor stasis in both models. In summary, BBO-10203 is a first-in-class PI3 kinase alpha RAS breaker that blocks the specific interaction between alpha and KRAS isoforms. It inhibits AKT and tumor growth without hyperglycemia. BBO-10203 is currently in IND-enabling studies. This work is the result of a long and very productive collaboration between BridgeBio Oncology Therapeutics, the RAS Initiative at Frederick National Labs, and Lawrence Livermore National Laboratory. Thank you very much for your attention.
Our third abstract is Trastuzumab deruxtecan in combination with Anastrozole or fulvestrant in patients with HER2-low HR-positive advanced metastatic breast cancer, phase 1, open-label, multicenter dose expansion trial, DESTINY-Breast08, by Dr. Kamal Javeri.
Thank you so much. On behalf of all my co-authors and the entire study team, I'd like to thank the organizing committee for this opportunity to present the results from the DESTINY-Breast08 trial. These are my disclosures. So DESTINY-Breast08 is a 2-part study with a dose-finding phase and a dose expansion phase, which was really designed to understand the safety, tolerability, and anti-tumor activity of various combinations with T-DXd, including the combination with endocrine therapy, the latter in ER-positive HER2-low breast cancer, HER2-low being defined as IHC1+, or 2+, that is ISH not amplified. The results really reported today are from the dose expansion phase of T-DXd plus Anastrozole and T-DXd plus fulvestrant. To be eligible for this study, patients had to have one measurable site. They were not allowed to have any prior chemotherapy and no more than one prior line of endocrine therapy with or without a targeted therapy. A total of 21 patients were treated with T-DXd with Anastrozole, 20 patients were treated with T-DXd plus fulvestrant. I'd like to highlight about a third of these patients had no prior therapy for their metastatic disease before study enrollment. For the others who received one prior line of endocrine-based regimen, all but 3 patients in the fulvestrant cohort received a combination of CDK4/6 inhibitor with endocrine therapy. The 3 patients who did not receive the CDK4/6 combination were treated with endocrine therapy alone. Median duration of follow-up in the Anastrozole arm was 20.2 months and was relatively shorter in the fulvestrant arm at 15.2 months. At the time of the data cutoff of August 16, 2023, 29% in the Anastrozole cohort and 35% in the fulvestrant arm were ongoing study treatment, and disease progression was the leading reason for treatment discontinuation in both arms. Here are the safety results. So I'll draw your attention to the right side of this table. First of all, safety evaluations were comparable to the safety that we know of individual agents alone. When we look at the combination of T-DXd with endocrine therapy, about 51% had any adverse event of grade 3 or higher. 42% had an adverse event of grade 3 or higher that was possibly related to either drug. About 24.4% had AE leading to discontinuation of Trastuzumab deruxtecan. There was one patient that had death on study, and this was attributed to disease progression and drug-induced pneumonitis by the investigator, but per the adjudication committee, the ILD was not attributed to be drug-induced. There were a total of 5 cases of drug-induced pneumonitis or ILD, all of which were grade 2. At the time of the data cutoff, 2 had resolved, 1 was resolving, and 2 were not resolved. 4 of these 5 patients had at least one potential risk factor for developing ILD pneumonitis, including renal impairment, prior nodal radiation in the thoracic region, or advanced age. Shown here are the efficacy results. As you can see on the right, there are some visual similarities in the waterfall plots between these 2 cohorts. Again, the median follow-up in the fulvestrant arm is slightly shorter at about 15.2 months, and when numerically we look at the overall response rate, in the anastrozole cohort, the overall response rate was 71.4%, and in the fulvestrant cohort was 40%. Median duration of response in the anastrozole arm was 9.8 and was not evaluable in the fulvestrant cohort. Median progression-free survival was 13.4 months in the anastrozole arm and not evaluable in the fulvestrant arm. Very important to highlight that 15% of the patients in the T-DXd plus fulvestrant cohort withdrew consent and discontinued study treatment before disease progression. So in conclusion, the safety profiles for T-DXd plus endocrine therapy combinations were generally consistent or comparable to the known safety profile of both agents. T-DXd in combination with anastrozole or fulvestrant was active in chemotherapy-naive patients with HER2-low hormone receptor positive metastatic breast cancer, demonstrating encouraging anti-tumor activity. However, these are small data sets that limit the interpretation of the efficacy results, and further research to evaluate T-DXd in combination with endocrine therapies is warranted. I'd like to thank all the patients and their families who participated in the study staff, and thank you all for your attention.
Thank you so much. We will move on to the phase 3 study comparing Trastuzumab emtansine and Trastuzumab, Pertuzumab, and docetaxel in older patients with metastatic HER2-positive breast cancer. Dr. Akihiko Shimamura.
Thank you, Dr. Kakuramani. I am very honored to have a presentation at this symposium. I am presenting a result of JCOG 1607 HER2 study on behalf of JCOG Breast Cancer Study Group. So this is my disclosure. Systemic chemotherapy with anti-HER2 therapy is the standard of care for HER2-positive advanced breast cancer. Patient outcomes have improved remarkably with the use of novel anti-HER2 drugs, including Trastuzumab, Pertuzumab, and Trastuzumab emtansine, TDM1. Based on evidence from an international pivotal phase 3 study, the combination treatment comprising HP and docetaxel HPD is highly recommended as the first-line treatment for patients with HER2-positive advanced breast cancer. In contrast, for older patients over 65 years old of age, this regimen seems to be intolerable mentally and physically and impairs their quality of life. A new standard treatment with less toxicity and non-inferior efficacy for older patients is needed. JCOG 1607 HER2 study is a non-inferiority study to compare the TDM1 with HPD in older patients with advanced HER2-positive breast cancer. The primary endpoint was overall survival. The secondary endpoint was progression-free survival, breast cancer-specific survival, response rate, adverse events, and activities of daily life. The planned sample size was 250. However, the study was terminated early at 148 patients by interim analysis because the OS hazard ratio estimate exceeded the non-inferiority margin. The patient's background was well balanced. The median age was 71 and 70 years old. Most of the patients had good PS0 or 1 in both arms. Half of the patients had ER-positive disease. De novo stage 4 was 65%. Brain metastases were rare in both arms. 65% of patients had visceral metastasis. This is the result of the primary endpoint, overall survival. Median survival time was not reached in both arms. The hazard ratio was 1.263 with 95% confidence interval 0.677 to 2.357. 95% confidence interval was exceeded non-inferiority margin 1.35. TDM1 failed to show non-inferiority to HPD as a first-line therapy. Median progression-free survival was 15.6 months in the HPD arm and 11.3 months in the TDM1 arm. It looks better in the HPD arm, but was not statistically significant because of small sample size. This slide shows the safety summary. The safety profile was better in the TDM1 arm. Adverse events grade 3 and more are more frequent in the HPD arm. The most common adverse events were neutropenia, leukopenia, fatigue, diarrhea, and appetite loss in the HPD arm, and thrombocytopenia, elevated liver enzyme in the TDM1 arm. In conclusion, TDM1 failed to show non-inferiority to HPD in OS and PFS. Adverse events grade 3 and more are more frequent in HPD arm, especially leukopenia, neutropenia, diarrhea, fatigue, and appetite loss were common. HPD therapy is a standard of care as first-line treatment for HER2-positive advanced breast cancer, regardless of age. Detailed analysis, including geriatric assessment, is needed to identify the patient population for whom TDM1 may be used as first-line treatment. Thank you for your attention.
We'll next go to report on cohort expansion of phase 1 study to investigate the safety, tolerability, pharmacokinetics, and anti-tumor activity of BB1701 in patients with locally advanced metastatic HER2-low breast cancer by Dr. Pam Munster.
Good afternoon. On behalf of my co-authors, I'd like to thank the organizer for selecting this abstract and all the study team and sponsor for their hard work, and most importantly, the patients for participating. Here are my disclosures. They're also to be found online. BB1701 is an antibody-drug conjugate consisting of a HER2-targeted humanized IgG1 kappa monoclonal antibody and eribulin linked via a cathepsin-cleavable valent citrulline linker with a DAR of 4. Eribulin is a microtubule inhibitor indicated for the treatment of patients with metastatic breast cancer and unresectable advanced liposarcoma. After internalization by HER2-expressing cancer cells, free eribulin is cleaved from the ADC, causing a direct cytotoxic effect to the cancer cells and via bystander effect to the neighboring cells. Eribulin is a well-established agent in breast cancer and has efficacy regardless of HER2 subtype or breast cancer subtype. It exerts anti-tumor activity via multiple mechanisms, including tumor reoxygenation, tumor immune modulation, and a repression of EMT and hypoxia markers. This study enrolled patients with HER2-low expression, HER2-low defined as either IHC positive and FISH negative or IHC 1+. Patients had to be progressed on at least 2 prior lines of therapies. We enrolled 4 cohorts ranging from 1 to 1.6 milligram per kilo given every 3 weeks. Baseline characteristics in 40 enrolled patients included a median age of 55 years, mostly females, with an ECOG of 0 and 1. IHC 2+ FISH negative and IHC 1+ was evenly distributed with 55 and 45%. Patients all had to have at least 2 lines of prior therapies, with 40% of our patients having had 4 or more prior therapies. There were no grade 4 or grade 5 adverse events found, and we did not see interstitial lung disease. The treatment-related adverse events focusing on grade 3 included peripheral and peripheral sensory neuropathy at 7.5 and 5%. We did not see grade 3 ALT and AST liver function abnormalities, and myelosuppression for grade 3 was 5 or less %. With regards to tumor response, 38 of our 40 patients were evaluable for anti-tumor efficacy. Our overall response rate in the 1.6 milligram per kilo dose, evaluating only confirmed responses, was 30%, with a disease control rate of 80, 89, 80, and 60%. Looking at efficacy by best percentage change in this waterfall plot, you can see that we found anti-tumor activity across all studied dose cohorts, with maybe a deeper and even a CR in the higher doses. This swimmer's plot looks at the durability of treatment. We expanded 2 cohorts, 1.2 in green and 1.6 in red, with 18 and 10 patients enrolled respectively. As you can see here, the durability of these patients suggests that 1.2 milligrams may be an effective and potentially more tolerable dose. Several patients have been on trial and staying on trial for more than a year. Activity is also seen in patients receiving prior anti-HER2 ADCs. In one case, a patient has a 9-month confirmed partial response after being treated with Trastuzumab deruxtecan, and another case is the ongoing complete response rate after disitamab vedotin. BB1701 treatment duration was longer than the prior therapy. So in conclusion, BB1701 has demonstrated promising preliminary anti-tumor activity in HER2-low expressing breast cancer, including patients who received prior anti-HER2 ADCs, and a minimum of prior lines of therapy. BB1701 has a manageable safety profile, and I truly appreciate and with gratitude to all the patients and their family and the entire research team. Thank you.
We will next move on to the Aviator TBCRC045 trial, a randomized phase 2 study on vinorelbine, trastuzumab alone, or combined with avelumab and utomilumab in patients with HER2-positive metastatic breast cancer. Dr. Adrienne Wax.
Thank you. On behalf of my co-authors, I'm happy to be here today to present the Aviator trial, or TBCRC045. These are my disclosures. So it's clear that trastuzumab acts in part via immunologic mechanisms, including antibody-dependent cell-mediated cytotoxicity and by generating adaptive immunity. In designing this trial, we sought to understand whether we could capitalize on these immune mechanisms by combining trastuzumab with immune checkpoint blockade, and then also further improve clinical efficacy by also engaging other immune pathways. So in that respect, 4-1BB is an attractive target because it's expressed on activated T cells and NK cells, where it increases their cytotoxic function. And also, its agonism synergizes with trastuzumab in preclinical models. So in this randomized phase 2 trial, we sought to examine the safety and the efficacy of trastuzumab plus chemotherapy, combined with anti-PD-L1 immunotherapy and the 4-1BB agonist utomilumab in HER2-positive metastatic breast cancer. Here's the original schema for the trial. Eligible patients had metastatic HER2-positive breast cancer, were previously treated with trastuzumab, pertuzumab, and T-DM1, had not received any prior immunotherapy, and were unselected for PD-L1 status. And those patients were randomized 1:2:2 to vinorelbine plus trastuzumab, to that doublet plus avelumab, or to that triplet plus utomilumab. The original design of the trial had 2 co-primary objectives. First, to compare the PFS for NHA versus NH, and second, to compare the PFS for NHAU versus NHA. However, in 2021, the clinical development of utomilumab was stopped, which was due to a company decision unrelated to this trial. At that point, we had enrolled 34 patients onto the NHAU arm, and we performed an interim futility analysis in which the utomilumab arm crossed the futility boundary with a hazard ratio of 1.14, and so enrollment to that arm was stopped, though notably there was no increased toxicity seen in that arm. And the trial then continued according to this revised schema where the patients were randomized between NH and NHA, and the remainder of the talk will focus only on those two arms. The trial enrolled between 2018 and 2023 at 16 TBCRC sites nationally, and the median follow-up here is 27.9 months. With 60 patients randomized, we had 88% power to detect an improvement in PFS with a one-sided alpha of 0.1. Here are the details of the population enrolled. 63 patients were evaluable for efficacy and safety. The median number of lines of HER2-directed therapy in the metastatic setting was 3. Approximately 1/4 of these patients were previously treated with T-DXd, and half were previously treated with a HER2 TKI. And all of these parameters were well balanced across the arms. Here's the primary endpoint of the trial, with the PFS for NHA shown in green and the PFS for NH shown in red. And as you can see, there was a statistically significant improvement in PFS with the addition of the avelumab, with a hazard ratio of 0.53 and a p-value of 0.025, although in this heavily pretreated population, the absolute benefit was small, with a median PFS of 3.8 months in the NHA arm versus 2 months in the NH arm. The overall response rate was numerically higher in the NHA arm as well, where the median duration of response was 15.8 months. Approximately 60 patients had baseline tissue that was evaluable for TILs and PD-L1. And as you can see, a higher TIL value had a trend toward correlating with a longer PFS in the overall population, as shown here. Conversely, there was no significant association between baseline PD-L1 score and PFS in the overall population. And when we broke down within biomarker subgroups, the numbers became very small to reliably analyze the PFS between the two arms. With respect to toxicity, the rate of grade 3 to 4 adverse events was similar between the two arms. There were 2 grade 3 immune-related AEs in the avelumab arm and no grade 4 to 5 immune-related AEs, and there were no unexpected treatment-emergent AEs in general. So in conclusion, there was significant improvement in PFS with the addition of avelumab to chemo plus trastuzumab in this population. However, the 4-1BB agonist utomilumab did not further improve PFS. Higher baseline TILs did show a trend toward association with more favorable outcome, as has been shown in other cohorts, and no unexpected toxicities were seen. Based on these results, further investigation of immune checkpoint blockade in pretreated HER2-positive metastatic breast cancer is warranted, and some is ongoing. I'd like to thank BCRF for their support of this trial, BCRF and Susan G. Komen for their support of the TBCRC, and importantly, all of the patients and their support structures who contributed. Thank you.
Thank you. And our last presentation is precautious modulation of metabolic and immunological parameters predicts tumor response to fasting mimicking diet plus chemotherapy in patients with early stage TNBC by Dr. Claudio Ranieri.
Good afternoon, everyone. Thanks for the introduction. So on behalf of the breakfast trial investigators, it is a great pleasure to show clinical data and biomarkers of response to fast mimicking diet in the breakfast trial. So these are my disclosures. So cyclic fasting or fast mimicking diets have been shown to enhance the anti-cancer effects of cytotoxic chemotherapy in tumor-bearing mice by modulating intratumor metabolism and by boosting anti-tumor immunity. Triple-negative breast cancer is exquisitely sensitive to glucose deprivation and in vivo FMD approaches, which synergize with chemotherapy, immunotherapy, or PI3K axis inhibitors. Combining cyclic fasting with the anti-diabetic compound metformin resulted in highly synergistic anti-cancer effects in several preclinical tumor models. And more recently, we demonstrated that cyclic FMD is safe, well-tolerated, and associated with desirable metabolic and immunomodulatory effects in breast cancer patients. So based on these premises, we designed the breakfast trial, which was a small pilot phase 2 study in which patients with stage 1 to 3 TNBC were randomized to receive preoperative anthracycline taxane chemotherapy in combination with 3-weekly FMD, or the same treatment in combination also with daily metformin. The study employed a Simon's two-stage statistical design with the aim of investigating whether one or both experimental treatments were able to increase the pathologic complete response rate from 45% according to historical data with the anthracycline chemotherapy alone to 65%. So the FMD regimen that we used in the breakfast trial was the same 5-day, 3-weekly FMD scheme that was shown to be safe and associated with positive immunomodulatory effects in a heterogeneous cohort of cancer patients. So between June 2020 and February 2022, we enrolled 30 patients, 13 of whom were randomized to chemo plus FMD, and 17 were randomized to chemo plus FMD plus metformin. But on February 2022, we decided to interrupt patient enrollment because the results of the Keynote 522 trial demonstrated that adding pembrolizumab to neoadjuvant chemotherapy not only improves PCR rates, but also event-free survival. So today I will show you results from 30 patients. So as you can see from this table, patient and tumor characteristics were well balanced in the two treatment arms. Patient compliance with the fast-mimicking diet was very good because the vast majority of patients were able to complete the maximum number of FMD cycles allowed as per protocol, which was 8. Patients who were overweight or obese at the beginning of the treatment underwent a much more pronounced reduction of their body mass index during the study treatment when compared to patients with normal baseline weight. The overall PCR rate in the study was 56.6%, and it was not statistically significantly different in the two treatment arms, but it compared quite well with historical PCR rates in patients treated with the same chemotherapy regimen and in similar clinical settings. In terms of systemic metabolic modulations, the FMD resulted in significant but reversible reduction of blood glucose, insulin, IGF-1, and LDH levels, regardless of metformin use. Then, to investigate the impact of the experimental treatment on intratumor metabolism, we performed bulk RNA sequencing analysis in tumor biopsy specimens collected at baseline and after one treatment cycle. And what we found by gene set enrichment, gene set variation analysis was a precocious downregulation of pathways related to glucose, pyruvate, and mitochondrial oxidative metabolism. And interestingly, these signals were only observed in the subset of patients achieving PCR, and regardless of metformin use. Then, to understand the impact of the treatment on intratumor immunity, we performed the convolution analysis of transcriptomic data to estimate the proportion of tumor-infiltrating immune cell subsets. And what we found was a precociously increased infiltration by NK, NKT, and central memory CD4 and CD8 positive T cells after just one treatment cycle. And again, these signals were specifically observed in a subset of patients achieving PCR. In conclusion, cyclic FMD with or without metformin is safe and associated with promising tumor response rates in combination with preoperative chemotherapy in early-stage TNBC patients. Patients who are overweight or obese at baseline undergo more significant long-term BMI reduction after the study treatment when compared to patients with normal baseline weight. A precocious downregulation of intratumor glycolysis and mitochondrial metabolism, or a precocious increase of tumor-infiltrating immune cell subsets are potential predictors of clinical benefit from FMD plus chemotherapy. And finally, ongoing clinical trials will eventually clarify whether adding cyclic FMD to standard treatment can improve tumor responses and potentially also long-term clinical outcomes in specific clinical settings. And in this perspective, we have recently initiated the larger multicenter randomized trial, Breakfast 2, which is investigating whether adding 3-weekly FMD to standard preoperative chemoimmunotherapy can increase the PCR rate in patients with stage 2 or stage 3 triple-negative breast cancer. We did not include metformin in this new trial because it was not associated with striking anti-tumor effects in combination with FMD, but it was associated with a higher incidence of diarrhea. I would like to thank all the patients who participated in the breakfast trial and their families. Thanks to the foundations, associations, and companies that support our independent research in this field. And of course, thank you very much for your attention.
I want to thank all the presenters for their wonderful work. I want to thank you all for listening in, and this concludes the session. Thank you.